We're going to talk about Diltiazem, also known as Cardizem. It's a calcium channel blocker. It blocks the slow calcium channels in the cell wall. It slows sinoatrial and atrioventricular node conduction, and it causes coronary artery vasodilation. So we start in the SA node, we go down to the AV node, we go through the bundle of His, we branch off into left and right bundle branches, and then we go down to the Purkinje fibers. And that's our cardiac conduction. So when we look at our sodium, potassium, calcium channel pump, if we remember this from school, we have our fast channels here, which are our sodium and potassium channels. And then we have our slow calcium channels. And those take ATP for active transport. So if we look at our protocol here, we'll go down and we'll say, okay, monitor vital signs, recognize if it's symptomatic, so we have a heart rate greater than 160, blood pressure less than 90, so call for ALS if symptomatic. Advanced are going to start an IVIO. We're going to give a normal saline bolus, and we're going to check for pulmonary edema. We're going to try a Valsalva maneuver ×3. All right, so we're going to get down to the paramedics. So if stable and symptomatic, and if it's regular, we're going to go with the adenosine. And here's a change. We're going to start out with 12. We're not going to do 6 anymore. Start out with 12 if it's regular. And then we're going to do a repeat if we need to. However, if it's irregular, we're going to go to Cardizem, 15 to 20 milligrams in 100 milliliters of normal saline with a 10-drop set, and just run it wide open. Because ultimately you can give it over 2 minutes. So that 100 ml is going to run in quickly, and it's not going to do any harm. So if they're unstable, you're going to synchronize CardioVert. However, the thing you want to be careful is with irregular, so AFib, and synchronized cardioversion, we have to consider the fact that if it's greater than 48 hours, we can cause them to throw a clot. And they can have a stroke, a pulmonary embolism, myocardial infarction, or something like that. So we can cause damage. So then we come down here to the special considerations. So we want to consider Wolff-Parkinson-White if heart rate's over 220 and they're young. And if they have Wolff-Parkinson-White, we want to avoid adenosine and Cardizem. And the reason for that is that we can lower the VFib threshold and we can send them into VF. So the treatment for that is going to be amiodarone, 150 diluted in 10 mLs, and we're going to give it slowly. All right, so Cardizem, contraindications. Obviously, if they're allergic or very sensitive to it, we don't want to give it. So if they're slow and hypotensive, we don't want to give it. So 2nd and 3rd degree AV block, hypotension, cardiogenic shock, ventricular rhythms. Now these two, sick sinus syndrome and WPW, we also don't want to give it. In the setting of MI, acute MI, we don't want to give it. And we don't want to give it to VTAC. So let's talk about WPW. How are we going to recognize it? So it's characterized by the presence of an accessory pathway, also known as the bundle of Kent. So it's between the atrium and the ventricle, and it can cause what's called a pre-excitation or earlier activation of the His-Purkinje system. So what you're going to find is you're going to find this delta wave, or this slurring of the QRS right here. The slurring of the R wave right here. So the PR interval less than 120 milliseconds, slurred upsloping of the Q wave, the delta wave. That's going to be your defining of the WPW. Now let's talk about sick sinus syndrome. So the thing about sick sinus syndrome is that you may see irregularities that might kind of look like AFib, but what you're going to see is these long sinus pauses, these sinus arrests right here. So you may see periods of tachycardia and then sinus pauses or sinus arrests. So you need to be very careful to look for the fact that you're going to have an actual sinus rhythm with defined P waves and then the sinus arrest. You want to give caution in renally impaired patients. So I hope this helped, and if you have any questions, as always, give me a shout.